Okay, so today we're going to look at some spinal cord syndromes and try to relate the clinical presentation of these syndromes with the anatomy of the spinal cord. Let's just start with a quick overview of the anatomy of the spinal cord. This cross-section of the cord shows the different spinal tracts. On the left in red are the descending tracts, and on the right in blue are the ascending tracts. And it's important to understand this topographical anatomy so that when you think about different parts of the cord being affected, you can think about which tracts are related to that part of the cord. However, it's also important to understand the longitudinal anatomy of the cord, and we're going to look first at the ascending tracts, which are divided into two main groups: the dorsal column and the spinothalamic tracts. The dorsal column, these tracts ascend on the same side of the cord as the fibers enter the cord, and then in the brain stem they then cross over to end in the contralateral post central gyrus of the cerebral hemisphere, whereas the spinothalamic tracts usually cross at the level at which the fibers enter or within a few segments, and then ascend on the contralateral side of the cord. The main descending tract is the pyramidal or corticospinal tract. The fibers originate in the precentral gyrus of the cerebral cortex. They descend through the brain and brainstem on the ipsilateral side, but then they cross over in the decussation of the pyramids in the medulla and the pons, and then descend within the spinal cord on the contralateral side and supply motor sensation to the contralateral side of the body. So the left precentral gyrus will supply the right side of the body. Let's think of a few cases. Have a read of this case. A 68-year-old man after a road traffic accident in which he suffered an acute hypoflexion injury of his neck. He complains of pain in his neck and has lost pain and temperature sensation below the nipple line. He also has weakness of his legs. Vibration and position sense are intact. Pause the video and see if you can work out what's going on here. So this is anterior cord syndrome. The area affected is the anterior 2/3 of the cord. So the corticospinal tracts and the spinothalamic tracts will be affected, but the dorsal columns remain intact. From this you can work out what the likely symptoms will be. These patients tend to have paraplegia. According to the degree of injury, this may be incomplete. The ascending tracts that are mostly affected are the spinothalamic tracts, which leads to a loss of pain and temperature sensation. But as we said before, the dorsal columns are preserved, so the patients have normal vibration, position, and 2-point discrimination. There is autonomic effect, and this tends to cause postural hypotension and may cause sexual and urinary dysfunction as well. These lesions are usually caused by hyperflexion or by non-trauma situations like aortic dissection leading to occlusion of the anterior spinal artery, and this can cause loss of blood supply to the anterior 2/3 of the cord. The second case is a 67-year-old female patient with known cervical spondylosis who presents 2 days after a fall at home. She has suffered a hyperextension injury. The patient is unable to move her upper limbs, but power to the lower limbs is intact. Think about what is a likely injury, and if there is a blood vessel involvement, what blood vessel might be affected. So this one is central cord syndrome, and the area of injury tends to be limited to the central part of the spinal cord. These injuries are due to several mechanisms. There's contusion of the cord after a hyperflexion injury, particularly in older people with spondylosis, and this leads to damage to the central part of the cord. There may be bleeding, which is more prominent centrally, which of course will cause damage to the cord. And finally, the penetrating arteries from the anterior spinal artery, they go deep and then fan out from that deep initial penetration of the cord. So if they are obstructed, the cord tends to be most affected centrally. Just one thing we didn't talk about with the anatomy, which is significant here. If you look at both the corticospinal and the spinothalamic tracts, you can see lamination of the cord, which is to say that the parts of each tract that supply the upper part of the body tend to be more centrally placed, and as we go lower down the tract, the more distally placed fibers are. So for the spinothalamic and for the corticospinal tract, the more centrally placed fibers would be for the cervical region or the thoracic region, whereas the more laterally placed fibers will be for the lumbar and sacral region. You can also see that there's some lamination with the dorsal columns, but this again goes from dorsomedial to dorsolateral. So the cervical part is the most lateral and the sacral part is the most dorsomedial, as seen on the diagram. So with the central cord, you will get motor paralysis, but because of the lamination, the upper limbs are more affected than the lower limbs. And there's similar pattern with the ascending tracts. Both ascending tracts can be affected, both the vibration sense, or the dorsal column, and more importantly, the spinothalamic tracts. And again, the upper limbs are affected more than the lower limbs. In this condition, urinary retention can be common, but lower limb signs are usually less prominent than upper limb signs and are more variable, depending on the extent of the lesion. Here's another patient with shot in the back, and he has heavy section of the spinal cord. Pause the video and see if you can tell me what clinical features may be associated with this injury. Yes, this is Brown-Séquard syndrome. So one half of the cord is affected. Of course, it's not that perfect, but one side rather than both sides. We can figure out what's going to happen. The descending tracts have already crossed up in the brainstem, and therefore you get ipsilateral paralysis. With the ascending tracts, it depends on which tract we're talking about. So for the dorsal columns, these will cross up in the brainstem, and therefore the loss of sensation, which is vibration, position, and 2-point discrimination, will be on the ipsilateral side. Whereas for pain and temperature sensation, these cross at the level of the cord, which is below the lesion, and therefore the part of the body that will be affected is the contralateral side. According to the specific lesion, you may have other features such as Horner's syndrome, which is ipsilateral, or involvement of the spinocerebellar tracts, which would cause ipsilateral ataxia. Just one last situation. A 38-year-old man with COVID-19. Well, a couple more situations. So brought with tingling of his hands and feet and double vision. He has weakness in his legs, which has now progressed to include the small muscles of his hand. And then pause the video and see if you can work out what might be going on here. So this is Guillain-Barré syndrome. We're not going to dwell on this. We have talked about Guillain-Barré in our presentation on peripheral neuropathy. But just to remember, this is not a spinal cord lesion. It's a post-viral ascending demyelinating polyneuropathy. usually post-infectious, and one of the classic features is that there is albuminocytological dissociation on the lumbar puncture, so high protein but relatively normal cell counts. Here's another one, a 38-year-old female with a 5-day history of tingling of the feet and hands, which has slowly progressed to increasing weakness and loss of blood and bowel control. She has a sensory level at the nipple with flaccid paresis of the arms and legs. Again, stop the video and see if you can work this one out. So this is a spinal cord problem. It's transverse myelitis, and the causes are multiple, as listed on the left-hand side, including autoimmune disease, vasculitis, viral infections, toxins, and trauma. Patients often present with band-like radicular pain, which then progresses to sensory loss and then motor loss. And the degree of progression and the degree of severity of the neurological symptoms can help us to classify these patients and prognosticate. Finally, a 28-year-old was fallen from a height and presents with loss of sensation below his clavicles. He's hypotensive but not tachycardic, and his peripheries are warm and dry, and he's noted to have priapism and loss of sphincter control, as well as a sensory level at the clavicles. Pause the video and see if you can remember anything about this particular condition. Yep, so this is spinal cord transection, which presents with both neurogenic shock, that being the cardiovascular consequence of complete transection of the cord, hypotension, bradycardia, and vasodilation, and spinal shock, which is the immediate neurological impact of cord transection. Basically, a complete loss of function below the lesion, leading to loss of sensation and flaccid paresis. Bearing in mind that some of this is just due to contusion of the cord, and some of this function may return with time. Priapism is used as an indication of complete cord transection because it indicates that the local spinal reflexes affecting the penis have been separated from the spinal cord control from the lung tracts. Sphincter tone may be lost either temporarily or permanently, but usually local sphincter reflexes return with time. The use of steroids for spinal cord lesions has been recommended in the past, but is somewhat controversial due to the high dose of steroids used and the risk of side effects. So if you have any questions or comments, you can post it on our chat, or you can present your questions in class. In summary, we looked at spinal cord syndromes, transverse myelitis, cord transection, and Guillain-Barré syndrome, all of which can be topics you encounter in your Part 1 exam, and also that you will see in your practice as an emergency physician. Thank you.